Hello, everyone. I'm Justin Anderson, Dartmouth's Vice President for Communications. I'm coming to you today from my office in downtown Hanover on a beautiful, if somewhat frigid, winter day. I'm joined by Dave Kotz, Dartmouth's Interim Provost, and Rick Mills, Dartmouth's Executive Vice President. Dave and Rick lead Dartmouth's response to COVID-19 and are familiar faces to viewers of this webcast. Another familiar face is Lisa Adams, who is also joining us. Lisa is Associate Dean for Global Health, Director for Global Initiatives, and a Geisel faculty member, in addition to being a member of the COVID-19 Science Advisory Group. Dave, Rick, Lisa, welcome.
Good to see you.
Thanks, Justin. Good to be back.
So I'm going to start today with the one doctor, the medical doctor, that is, that we have with us. So Lisa, that's you, unless there be any confusion. I want to start with you as the resident expert among the four of us and ask you to help us sort of set the stage for the conversation. So the last time we did one of these, when I spoke with Dave and Rick, it was the very start of winter term in early January. Omicron was spreading like wildfire and New England was hunkering down. Students had just returned to campus and positive cases were about to reach levels that we had not seen during the first 2 years of the pandemic. And we didn't know how lethal Omicron might be or whether or not the vaccines would even work. In short, people were seriously and understandably on edge. The numbers went way up, but things have not really played out as expected back in early January. In fact, you told the Valley News this weekend, reacting to the fact that there were no serious illnesses among our community that we know of and no hospitalizations. You said what we are seeing are higher numbers, but no hospitalizations that we know of. So I'm wondering if you could talk a little bit about sort of where we are in the midst of this surge and where we are over the course of this pandemic. Are we still in a pandemic? Are we still in an emergency? So where are we right now?
Yeah, I'm very happy to address this question. And I do stand by what I said to the Valley News in terms of, I think that there is good news to be seen now in terms of we did see many cases. We have peaked. We may be starting to turn that corner just about now, as New Hampshire is as well. We'll see as we look at 7-day averages over a few days. But this is, I think, the fact that we have not had any serious adverse outcomes is very good news. So in terms of the pandemic, there's different stages to a pandemic. There's the pandemic stage, and then when you come out of the pandemic stage, you move into what's called the deceleration phase, and then there's the control phase and the elimination phase and the eradication phase. So just very briefly, the pandemic phase is when numbers are still increasing, as we have been seeing on our campus, in our state, and really across the country and elsewhere. And so we are really looking to see that deceleration phase. We've seen it at different stages. In this pandemic, I think this has been referred to as the fifth wave that we're in now. But I do feel like with our vaccines and booster shots, this, we hope, is going to be the last of the waves. But we really do want to see that our cases are starting to come down. When we start to see that consistently, then just in epidemiologic terms, we move into the control phase, which is reducing a disease prevalence to a locally acceptable level, which, and I always reinforce this to my students, is as a result of deliberate efforts. It doesn't happen really on its own. And continued intervention measures are required to maintain that reduction. So tuberculosis disease I work with is a good example of that. So we would continue to have interventions to help us control the disease. And then once a disease is under control, we then can talk about the elimination, decreasing it to almost zero incidence in various geographic areas. Measles is a good example. Polio is a good example of that. And then eradication, of course, the only disease we've ever eradicated is smallpox, and that's when the disease is fully extinct. So we do want to know that we're getting into that deceleration phase before we can get to that control phase. And we are not at a control phase just yet. No one would say we're at an acceptable level of COVID cases, but that's where we want to be going. So I really hope that we are starting to enter that deceleration phase, but it is only going to be through our continued efforts, our continued deliberate interventions that we're going to be able to maintain, to reach the control phase and to be able to maintain it.
Quick follow-up, Lisa. So over the course of the last 2 years, there have been times like this past summer when, the numbers went down and it seemed like we were sort of coming out of this. Would you have called that the deceleration phase or not?
Right. So some of this you can only see in hindsight, right? As we see, peaks come up, and we knew that there were going to be new variants coming out, because as long as a virus is circulating, it is mutating, and that's when we are at risk of having, these new variants put us into another wave of the pandemic. I am really encouraged by the effects of vaccines plus boosters that we're seeing. And I think that is something that is going to help us really, really stay in that deceleration phase and be able to approach the control phase next.
Dave, if I could turn to you, Lisa just mentioned boosters, and as it happens, January 31st is right around the corner, and that is the date by which we expect all Dartmouth community members to have been boosted and to uploaded that proof of having received a booster into our database. So can you talk a little bit about why we're doing that and the efficacy of boosters?
Yeah, sure, Justin. It's an important deadline. It's Monday, January 31st, just as you say, next week. And we are requiring all Dartmouth people, faculty, staff, and students to receive a booster by January 31st or within 30 days after they become eligible for a booster. And to make that easier, by the way, we have a clinic on Monday the 31st itself, open to everyone in the Dartmouth community. And I noted also for family and household members. So take a look at the website for that. It's a great opportunity to get yourself and your household boosted. The reason why we think that booster is so important for both the individuals in our community and for the community as a whole is that boosters have been shown to significantly increase protection against serious illness. And it also, as I read the data most recently, shows that it's less likely for someone who's been vaccinated boosted to become infected and to become infectious and to infect others in their household or community. And so it serves both the individuals and the community. And that's why we think it's so important that we are requiring everyone to get boosted by Monday or as soon as they can after being eligible.
Lisa, because we have you here, I'm gonna come to you with a follow-up question regarding boosters, and I know you're a big believer in boosters. I've started to hear a little bit of rumors, I guess, or claims that the booster, receiving a booster, it may not be safe. There are reports that perhaps it causes an increased likelihood of myocarditis, and people they just want to make sure that what they are putting into their bodies is not going to do them harm. What do you know about that or the potential side effects?
Yeah, I think the vaccines that we have against COVID, which includes the booster shots, have been administered to so many individuals, right? We have so much data about the safety of these vaccines and boosters, maybe more than we have about many other vaccines that we may recommend routinely. And again, I think one way to think of it too is that what is the risk of getting a booster versus getting the risk of getting COVID? So I think, a lot of these concerns that have been raised, the concern around getting a blood clot or myocarditis, the risk with getting any of these side effects is much greater if you get COVID. So I think that the safer route to go is to get your booster and protect you from getting COVID. And again, as Dave mentioned, we know that they protect the individual as well as those around them. And if you look at the graphs that we are studying on a regular basis, where you look at at hospitalizations, deaths, and you see the divergence of those two lines between those who are vaccinated and now vaccinated and boosted versus those who are not, they diverge in such a great way. There's just no question when you start looking at those graphs. And the new data are suggesting that the effectiveness of the booster vaccines during in areas where Omicron is the predominant variant, which is pretty much every place now, that's really encouraging too, that the vaccines and boosters seem to be working against Omicron, which had been a question until recently.
Rick, I don't want to leave you out. I'm going to bring you into this conversation. I'm going to ask you to talk about testing. So, once a week, I take I do my swabs, I put it in my test tube, I put it in the baggie, and I walk it over to a drop box. I do that at least once a week. What do I have to look forward to in the coming weeks? Are we going to do more testing? And if so, why? Or are we going to do the same amount or less testing? And if so, why? So basically, how are we thinking about testing as we move forward?
Sure. Dave and I and the Science Advisory Group have been talking a lot about testing, as you might expect. And I think one of the things Lisa just referenced, Omicron and its pervasiveness in the community, really everywhere, it's certainly changed our perspective on the value of the PCR testing that was really quite useful last summer and fall. With the prevalence, the transmissibility of Omicron and the time to get to a test result means that it's not nearly so useful in trying to contain spread of the virus as it was in the earlier variants. And we recognize it's a bit of a burden on the community to go through the testing. We've also introduced a second kind of test. In addition to the PCR test, we have rapid antigen testing that we're using for symptomatic diagnostic testing, just to screen folks who aren't feeling well, and also as a way to help people emerge from isolation early. So there are two different kinds of testing, and I think the question going forward is really going to be, how do we want to deploy those testing technologies? How will they offer us the most benefit? And what are the things that are no longer useful that we can step aside from? And I think you'll see some announcements about changes, probably not for winter term, but as we think about approaching spring term, as we think about the value of pre-arrival testing and arrival testing, we're going to be coming out with some new information about where we're headed with that, but we don't have it fully developed yet.
We'll look for that. So Dave, if I could go to you, we've talked on this webcast already, and we obviously see it when we look at the news, talk about the fact that it seems that the illness that Omicron causes is sort of more mild. The disruption, however, that it causes is in many cases anything but. We look around our campus and we see students who are missing classes and have to make up time. We see faculty who are working hard to support those students and to improvise in the classroom. We see staff members working long, late hours, trying to support the community, and sometimes feeling like they're putting themselves in harm's way. So we got a pretty stressed out community right now. We're all happy to be here, or for the most part, we're all very happy to be here, those of us who are, but that doesn't mean that our lives are perfect or some days going, smoothly. So I'm just wondering how you react when you know that you're surrounded by colleagues who are struggling.
Yeah, I definitely sense the same thing, Justin. I hear it from faculty colleagues, from students, and from staff. It's exhausting right now. We just passed the year 2 anniversary of the first case in the United States, and there's a long slog ahead, I'm sure. Right now, I think one of the biggest challenges is the frequency of people being absent, right, due to their need to isolate and recover perhaps from symptoms. And that is affecting, as you said, students in the classroom, that's affecting staff in various operational units around campus, which causes others to work extra hard to make up. So I recognize and in some ways celebrate everyone's efforts to make this work, even though it is difficult. And I know that for the students who have to miss class for a few days, it can be a challenge to keep up and to catch up. And for the faculty who are working so hard to make it possible for students to keep up, I really just want them to know that I appreciate their flexibility, their perseverance, and their understanding, really, of the challenge that we're all facing. So I think, as you said, the faculty are being creative in the classroom to make alternative approaches possible. Nothing is going to be perfect, but everybody's trying their heart, and I really appreciate that.
And Justin, I would just pipe in and I echo everything Dave said and observe that this is a moment for all of us to care for each other in the community. And it's one of the sort of resilient elements of the Dartmouth community that I most appreciate, that we aren't an anonymous large campus. We know each other, we live together, we eat together, we work together. And just finding a little more patience, a little more understanding, as you don't know what the person next to you or the person across the counter or the person at the front of the classroom is dealing with at home or in work. It's just a tough time for everybody, and try to provide as much sort of support and patience and goodwill as you can and bring it to the situation. Folks have been terrific, and we can't, I mean, Dave said it, we can't say enough about all parties trying to make this work and get through this, and we will get through it. It's just going to be a slog.
Well, Rick, something that we all can do for the community is wear a mask. So I wonder if you could talk a little bit about masking on campus and how we are approaching that, particularly as we see more and more just how effective masks and certain masks are.
Sure. And, you know, Lisa is probably better capable of talking about the specifics, but the data are clear. Masks work, and better masks work better for more time, reduce exposure, reduce transmission. It's also true at the same time, masks aren't fun to wear. As glasses wearers, we all know our glasses fog up, and when it's minus 10 degrees out and you go inside, it's no fun to wear a mask for a while. So it's try to do what we can to get vaccinated, get boosted, wear KN95s. The college is distributing them everywhere. If you have trouble finding them, look on the website, but at every place you can pick up the test kits and the swabs you were describing, there should be masks available too. And the more we do that and the more we slow the spread of this, the easier it will be to bend the curve down and get to the point that Lisa was talking about, where we begin to descend from this pandemic phase.
Well, I got to tell you, Rick, when I go outside, when it's 13 degrees, I put that mask on and I don't mind it at all.
So it's funny, as you walk around campus, you definitely see more masks than you did in the fall. I'd like to think it's because everybody's being more civic minded, but they are more comfortable, except when you're blinded by the mist that freezes up on your glasses and you fall and kill yourself. So it's a mixed bag, but wear masks, people, and thank you for doing it.
So Lisa, I want you to really nerd out on us and talk to us about the different kinds of masks. This is something I know you're dying to talk about. What's your favorite mask and why?
Yeah, well, I really like that the CDC issued this new guidance on masking, because I feel like it finally acknowledges the nuances in the different kinds of masks that are available and when you might choose to wear one or another. So, you know, they have a ranking system of masks, right? So we all know that those loosely woven cloth masks, they provide the least protection. If you get a cloth mask that has a nose guard, that's better, right? Because it's all about the fit and the seal. So the double or triple ply cloth masks was the nose guard or the next best thing. And then, of course, well-fitting surgical masks are at the next level. And then the KN95s and N95s. And the CDC, you know, looked at all the different kinds of masks. You know, N95 is the gold standard, of course, and those get fit tested and what have you. but that there's a whole alphabet soup of other masks with letters and numbers and stuff. But the KN95s, which is what we're distributing at Dartmouth, are the ones that they have found consistently meet the international best standards. So I like that we're giving out KN95s. That's what I actually choose to wear. And I love it when it sort of sucks in and sucks out when I breathe in and out, because I know that that's a really tight seal around my face. And that's what I see my students wearing too. I'm teaching this winter term, and it's been wonderful to be in the classroom again. And you know, my students in the classroom, they really buoy me. I say when I'm in the classroom, I almost feel like I'm levitating when I'm teaching. It's such a great feeling to be back in the classroom in person. And everybody's in such, you know, the morale is, it's been tough time, but I feel like there is good morale and camaraderie, at least among my students who are all interested in global health. So I do feel that we're able to wear the mask and kind of forget about it after a while. After I've been in the classroom wearing it for 15, 20 minutes, I almost forget that I have it on.
Actually, Lisa, that makes me want to ask you a question about your teaching. And what is it like to teach global health at this particular moment?
So the hardest part is that we have a lot of material to cover. We want to talk about malaria and tuberculosis and the HIV pandemic, and it's hard not to always be bringing it back to COVID because the concepts are so real. So if I'm talking about, like as I was just talking about now, the stages of disease control, elimination, and eradication, it's hard not to also say, well, as you all know, and bring it back to COVID. And sometimes I just worry that we're a little, you know, COVID overdone and there's some COVID fatigue. So I am aware of that and trying to make sure that we do, you know, make sure that we're talking about the concepts in relation to other diseases as well, that it's not all COVID all the time. But the students have been great in sharing wonderful experiences that they're having, both, you know, with COVID and in other areas of global health. It's just been a wonderful term so far.
So you were teaching about global health and pandemics before all of us became sort of pseudo epidemiologists. Did you ever think that you would actually be living through something like this?
I did not, and it's odd to be saying I've been teaching this class for almost 15 years, and to say these concepts that we would talk about, you're all living through them now. And I feel like the students sometimes are really engaged because they're experiencing, there's nothing theoretical about what we're talking about in that course anymore.
Lisa, tell us a little bit about your favorite coffee mug.
So this is shared by one of my infectious disease colleagues, Dr. Michael Calderwood, and I'll tell you, it's where we all can't wait to get back to. And the slogan is, make epidemiology boring again. I can't wait to get to a stage where nobody really cares what I have to say anymore, where the epidemiology I want to talk about is just not of interest because it's not on the front pages. It's not on everyone's minds every minute of every day. I'm looking forward to that day.
We all are, but we will always care what you say, Lisa. We will always care. And to make that point, I'm going to ask you another question. You mentioned the CDC guidance as it relates to masks, and that's sort of, you know, one of the things that people will come back to about the very beginning of the pandemic was the CDC guidance that masks, you know, might not be terribly effective. I can't remember what the exact guidance was, but it was that you didn't need to wear a mask or they wouldn't be so protective. And so that's obviously changed and evolved. And I understand how science works. You learn things and that adjusts the guidance that you're giving based on the knowledge that you are developing. But I'm wondering, how do we sift through all of the expert guidance and advice when it's not all the same? When you have the CDC saying one thing and you have perhaps the state of New Hampshire or the state of Vermont saying something else, and then you have you know, somebody like Anthony Fauci saying something that might be entirely different. All of these entities are legitimate, credible experts, but they're going to be saying different things. How do you, as an individual, make heads or tails of that? And then as an institution, how does Dartmouth make heads or tails of that and then come up with a sort of a coherent, evidence-based policy?
It's a great question, because, and what you're talking about is actually true expert opinion, right? Because we know there's also been a pandemic of misinformation, but leaving that aside and just looking at the expert bodies and individuals that are out there, it has been challenging. It has been challenging since the beginning days of this pandemic. And as you say, things have changed, and different scientific bodies and authorities don't always agree. What I will say, again, with now 2 years of experience, is that there tends to be a harmonic convergence. So authorities do tend to sort of meet, and there tends to be a consistent or consensus around some of these decisions in the end, but it can be a while before we get there. And what we all have done is looked at our federal guidance, our state guidance, our town guidance, and tried to make the best decisions for in incorporating our institutional guidance. And as an independent institution, there are times when we are able to make to take the expert guidance and make institutional policies and decisions that are best for our community. And that's what we've tried to do really from the very beginning.
And Lisa, it could be distilled down to 3 elements, right? Vaccination, boosting, and masking. And there's real convergence on those 3 elements.
Very clearly, yeah, there's no doubt about those. And so that's very nice to see now that there is consensus, there's consistent guidance, consistent messaging around those. Those are no longer, I think, in question.
So we have harmonic convergence on vaccinations, boosting, and masking?
I would say so, yes. There's
Good.
no doubt about that.
So Rick and Dave, if I could go to you to get sort of practical, you guys are tasked with, when there's not harmonic convergence, trying to figure out how to make policies that are going to keep the community safe, both physically and mentally, and allow us to pursue our mission and do the work that we came here to do. So could you talk, Rick, can you talk a little bit about how you make a decision when faced with something less than undeniable evidence, something that requires something less than just say, oh yes, we know this because it's been proven over and over and over and over again?
I think it starts and ends for us with consultation with medical experts, epidemiologists, teachers, and faculty who are in the classroom, talking to student groups, talking to staff. It starts and ends with not our going off in a room by ourselves and making a decision, but in fact, our getting out and talking to as many folks as we possibly can to understand perspectives, get information. And then I would say, Dave, we sift through that together and sort of challenge each other and try to arrive at what we think is the best amalgam of the different advice and information that we've received, always keeping in mind the principles that we started out with, which is preserving in-person education to the extent possible, minimizing serious illness on campus, and making sure people can live their lives safely.
Yeah, I would agree with all that, Rick, and add that in many ways it ends up being a balancing act. So we take all this information we receive from the scientific and medical community and from the various other constituencies that need to live and work here, and try to come up with a set of policies and procedures that are workable and that ultimately we think will best allow the community to achieve what Rick just said, the opportunity to continue with in-person education while also retaining a reasonably low risk of serious illness. And that is always, like everything that involves risk, a balancing act, right? And so we are also, every day trying to tweak and adjust and recognize, what is a practical approach that will allow us to walk that fine balancing act.
And Dave, before we started the webcast, I understand that you were yourself embracing winter and were out on the green doing some wicked hockey stops. That's what I heard.
Oh wow! Now that's you heard well, although No, I think you heard it might be exaggerated a little bit. No, I was out on the green ice skating just as the ice rink has opened here on the green. It's very exciting. It's a beautiful sunny day, good cold temperatures for ice skating, 15 degrees. My toes, by the way, are still not quite fully thawed, even an hour later. But it was fun to see a lot of students out there, some of whom had never. The one who said this was her first winter, and here she is out on the green, putting on ice skates and trying out something new. And it was just really exciting and fun to see. So I would encourage anyone who's in the area to come on to the green in the afternoons and rent some skates. They're free, and give it a whirl.
Sounds good. I know I'll see Rick out there very soon. So
I'm the guy with the hot chocolate in my hand, standing in my boots.
You're the après skate guy.
I'm the après skate guy.
So we're just about out of time, but I do, Rick and Dave, want to give either or both of you an opportunity to just sign off and share anything we haven't covered that you'd like to cover.
I think for me, it's just recognizing how hard this has been and is continuing to be, and asking for patience, forbearance, and forgiveness. And let's keep moving ahead. We really will get through this. Lisa described for us how pandemics ebb, flow, and end. And if we work together, we can get there.
Yeah, plus one on all that, Rick. I would say that I just want to emphasize again how much I appreciate everyone's hard work and perseverance and patience, and looking forward to the spring. The days are getting longer every day, and perhaps if things go well, this will be the downward trend that Lisa was talking about, and summer will be more pleasant than it is today. So.
Well, thank you for that, Dave, and thank you, Rick. And Lisa, thank you so much for joining us. That was really, really interesting. And you've just, I think, bought yourself another couple of visits to this webcast. So thanks. And I want to echo what Rick and Dave said. I am so grateful to be part of this community, and I am so inspired every day by seeing all of you do the jobs that you do so well. And just know that we are here. I am here to support you in any way I can. So I'll just end with that and to say thanks again. Bye-bye.